A 62-year-old male presents with recurrent thigh swelling. I am showing you axial T1, stir, pre-contrast fat-saturated T1, and post-contrast T1 magnetic resonance images of the proximal thigh. Please describe the findings.
The magnetic resonance images demonstrate a large, bilobed, predominantly fatty mass in the deep musculature of the proximal thigh. It suppresses on the fat-saturated sequences, but contains thickened, heterogeneous internal septa and non-adipose nodules that show prominent post-contrast enhancement.
What is your primary diagnostic concern?
The findings of a large, deep fatty mass containing thick, enhancing septa and soft tissue nodules are highly diagnostic of a well-differentiated liposarcoma, also termed an atypical lipomatous tumor.
What is the clinical significance of using the term atypical lipomatous tumor instead of well-differentiated liposarcoma?
They are histologically identical, but atypical lipomatous tumor is preferred for extremity lesions because they carry no risk of metastasis when completely resected. The term liposarcoma is reserved for retroperitoneal or mediastinal sites, where positive margins carry a high mortality rate.
What are the key magnetic resonance imaging features that help differentiate a well-differentiated liposarcoma from a benign simple lipoma?
A simple lipoma is homogeneous and has thin septa under 2 millimeters that do not enhance. Liposarcoma typically features thick septa over 2 millimeters, nodular non-adipose soft tissue components, and prominent contrast enhancement.
How does the myxoid subtype of liposarcoma differ in its radiographic appearance on magnetic resonance imaging?
Myxoid liposarcoma has a low fat content, typically under 25%. It appears as a T2 hyperintense mass resembling a cyst, but shows prominent heterogeneous internal enhancement post-contrast.
What are the 4 histological categories of liposarcoma?
The 4 categories are well-differentiated, dedifferentiated, myxoid, and pleomorphic liposarcoma.
Where should an image-guided biopsy be targeted in a heterogeneous fatty mass?
The biopsy must be targeted under ultrasound, computed tomography, or magnetic resonance guidance, specifically to the non-adipose, thick-enhancing septa or nodules, as biopsy of the mature fat component may lead to a false negative diagnosis of a lipoma.
Finally, what are your clinical management recommendations?
I recommend referral to an oncologic surgeon for wide local resection with negative margins. Chest and abdominal computed tomography staging is indicated if there is suspicion of dedifferentiation or a high-grade component.